tympanic membrane, also called the eardrum, is a thin membrane which separates the external ear from the middle ear cavity. It vibrates when sound waves enter the ear. Tympanic membrane rupture or perforated eardrum can result from infections or trauma to the ear, like removing earwax with sharp tools or due to iatrogenic injury during otoscopic procedures, or maybe sudden pressure imbalance between ear cavity and external environment, which is also known as acoustic barotrauma, like a loud noise from a bomb explosion or underwater diving. Infections is the main cause of tympanic membrane rupture. It can be either acute or chronic otitis media. Perforation of the eardrum leads to conductive deafness. Speaking of deafness, there are three categories of hearing loss: conductive deafness, sensory neural deafness, and mixed type. If there is a problem in 8th cranial nerve or vestibulocochlear nerve, it is unable to transmit sound signals to the brain, so that the brain cannot perceive the sound, and this causes sensory neural deafness. In conductive deafness, there is a problem in sound conduction, which means the sound is not travel along the external ear and middle ear to reach the eardrum. This may be because there is something blocked inside the ear cavity which stops the sound wave from getting through. Mixed hearing loss means the hearing loss is caused by the combination of the above two. In small uncomplicated perforations, deafness is usually temporary. But large perforations or perforation associated with infections may present with earache or otalgia, and ear discharge or otorrhea. The patient may also experience swelling of the ear due to accumulations of fluid or pus due to infection. If there is bloody discharge, it could be caused by trauma. If the infection in middle ear gets into inner ear, the patient may present with symptoms like tinnitus, vertigo, nausea, and vomiting. Vertigo is a sense of spinning after head motions, whether it may be the body itself or the surroundings. It occurs because of a problem in the vestibular labyrinth inside the inner ear, which helps to maintain the body's balance and equilibrium. The patient may hear whistling sounds or may sense air coming out from the ear while blowing the nose. Before we figure out why did this happen, let's take a look at the structure of a middle ear cavity. The middle ear cavity, also known as tympanic cavity, looks like a rectangular box composed of 4 walls, a floor, and a roof. The roof is formed by the petrous part of temporal bone, which separates middle ear from cranial cavity. The floor is formed by a thin plate of temporal bone, which separates middle ear from internal jugular vein. Lateral wall is made up of tympanic membrane. Medial wall is formed by the lateral wall of inner ear. Posterior wall is formed by the mastoid antrum, which separates the middle ear with mastoid process. Anterior wall is formed by a thin plate of temporal bone, which separates middle ear from internal carotid artery. Inside the middle ear, there are 3 small bones attached to the tympanic membrane: the malleus, incus, and stapes. There is an opening at the anterior wall, from which a small passage extends and connects with the nose, more specifically, the nasopharynx. This passage is called eustachian tube. Normally, when we sneeze or blow our noses, there is a rise in pressure inside the nasal cavity. This pressure passes through the eustachian tube and pushes against the tympanic membrane, causing it to swell up and balloon outward. But if there is a hole in the tympanic membrane, air will leak out, and sometimes even makes a whistling sound. Normally, A small perforation may heal spontaneously within 2 weeks. If there is underlying chronic otitis media, there is prolonged and repeated buildup of dead cells inside the middle ear, leading to development of a tumor-like growth which is called cholesteatoma. A ruptured tympanic membrane is usually diagnosed with routine otoscopy to visualize the site of perforation. But some small perforation might be missed during otoscopy. In that case, video orthomicroscopy can be used for identification. You can also perform hearing tests like tympanometry, audiometry, and Rinne's test. Tympanometry is a test that measures how the tympanic membrane moves in response to pressure changes inside the ear canal, with the results represented in graphs. Audiometry is a test to measure the hearing ability of each ear by testing through sound waves with different frequencies and pitch. We all hear sounds through two mechanisms, air conduction and bone conduction. When the sound wave from the air enters the external ear and middle ear, the tympanic membrane vibrates. Then the vibrations are transmitted towards the malleus, incus, stapes, and finally to the inner ear. Inside the inner ear, there is a receptor organ for hearing, which is known as organ of Corti. It consists of tiny hair cells, which transform vibrations into nerve impulses or action potentials. Then these action potentials are traveled along the 8th cranial nerve to the auditory cortex of the temporal lobe, where the sound is perceived and interpreted. This is how the air conduction works. However, in some cases, vibrations can directly stimulate the hair cells of the organ of Corti of the cochlea through the skull bones, without requiring the sound wave to pass through the external and middle ear. This is how we hear our own voice, and this is how bone conduction works. Now for Rinne test, let's start by placing a vibrating tuning fork on the mastoid bone. This causes vibration of the mastoid bone, which stimulates directly to the cochlea. Then the sound is heard, while bypassing the external and middle ear. After the sound is no longer heard, move the vibrating tuning fork to the external auditory meatus, approximately 4 cm from the ear. The patient should be able to hear the sound through air conduction. After performing Rinne test, ask the patient which ear hears the sound better. Normally, air conduction is better than bone conduction. If the patient hears better on air conduction, this is considered as a positive Rinne test. If the patient hears better on bone conduction, this is considered a negative Rinne test. If there is a hole in eardrum, it can vibrate as well as before. So the sound waves entering the middle ear cavity are not transferred to the inner ear through air conduction. However, the sound waves can be sent directly to the inner ear through bone conduction while bypassing the external and middle ear. That's why the patient is able to hear sound conducted through mastoid process, which means bone conduction is better than air conduction in eardrum perforations. So, keep in mind that in eardrum perforations, Rinne test is negative. In this test, negative results indicates an abnormal state in contrast to other medical tests, which is kind of confusing sometimes. Therefore, it's better to simply say whether the test is normal or abnormal, like bone conduction is better than air conduction, without using the term Rinne test is positive or negative. Small and complicated perforations may heal spontaneously within 2 weeks. Over-the-counter analgesics can be given for earache, and antihistamines like meclizine can be used for vertigo. In case of infections, consider giving antibiotics. But care must be avoided not to use antibiotics which carry the risk of ototoxicity, like gentamicin and neomycin. If bloody discharge continues due to trauma, manage according to ATLS guideline. For the patients complicated with cholesteatoma, the standard treatment is surgical removal of the tumor. As for permanent hearing loss, patient may require hearing aid devices. If spontaneous healing does not occur, consider temporary closure with interventional therapies like using a small piece of special paper or gel to seal the hole temporarily while waiting for the body's natural healing process. This procedure is also known as paper patch tympanoplasty or maryngoplasty. You can also use a small plug of fat from the earlobe to seal the perforation, which is called fat plug tympanoplasty. For persistent perforation, surgery is usually performed to close the hole permanently. In this procedure, the perforation site is repaired by using patient's graft tissue, which may be either fascia of a temporalis muscle or maybe the cartilage from earlobe. This can be done by using endoscope through the ear canal, which is also called endoscopic tympanoplasty, or giving incision behind the earlobe, which is called traditional tympanoplasty. That's all for now. See you guys in the next video. Study hard and take care.